Good morning. I'm discussing human ocular dirofilariasis and emerging zoonosis in the eye. Myself, Dr. Sanju Shankar. Dirofilariasis is an emerging zoonosis which is endemic to South Kerala, and it is really a concern, and that is the reason why I am here today with this topic. It is being caused by the genus Dirofilaria, of which the most common are Dirofilaria repens and Dirofilaria immitis, and it is being transmitted by female mosquito vectors, and this is a life cycle of Dirofilaria repens, which is notable to cause the ocular lesions. Now, the reservoir host are the dogs from where the disease is being transmitted by the female mosquito vectors to humans who are the dead end host. And in our area, there are various factors which is contributing to the growth of the vector population, which include natural water sources, humid climate, rainfall, heat islands, and stray dogs. Aim of my study is to analyze demographics, identify varying clinical presentation, management approaches, and treatment outcomes. Mine was a retrospective study of 33 patients with ocular dirofilariasis conducted at a single tertiary eye care center in Kerala of duration 8 years, and all patients presenting with acute ocular inflammation associated with itching and radiologically confirmed with a cystic mass was included in the study, and patients with loss follow-up being excluded. On analysis, out of the 33 patient study, 55% were females and 45% males, and the age of presentation ranged from 2 years to 88 years with a median age of 46 years, and all the 33 patients had a unilateral involvement. And the clinical presentation, the commonest symptom was acute onset eyelid swelling along with itching with associated pain, and the duration of disease ranged from 2 weeks to 8 months. According to the anatomical distribution, 55% had an eyelid involvement, 39% with orbital involvement, and 6% with conjunctival involvement. On clinical examination, the most common sign that was elicited was a palpable mass, followed by lid edema, congestion, chemosis, proptosis, and preseptal cellulitis. And the image in the right end, it is a case which presented only with a palpable mass without any signs of inflammation. And all those whom we had a clinical suspicion was sent for an imaging technique, which include an ultrasound B scan, which revealed a cystic swelling with a serpiginous structure with parallel echogenic walls and an echoic lumen, giving a tram track appearance, and an MRI orbit, which showed in T1 weighted MRI, hyperintense, well circumscribed rim with a hypointense core, and as in the image, T2 weighted MRI, well encapsulated hyperintense lesion with a hypointense rim. An MRI was used to assess the plane of involvement and exclude other abnormalities. And all the 33 patients, we started initially on medical management of tab prednisolone 1 milligram per kilogram body weight per day, tapered over 5 days, and tab albendazole 15 milligram per kilogram body weight in 2 divided doses, along with other symptomatic management. The treatment outcome out of the 33 patients, all were given initially medical management, of which 85% had complete cure, and they were sequentially followed up, while remaining 15% they had a persistence, either progression, recurrence, or a visible worm mass, which is an indication for surgical management. In surgical management, we did a surgical excision for which 60% underwent an eyelid lesion excision, 20% anterior orbitotomy, and 20% conjunctival lesion excision was done. And all the patients who underwent the surgical excision, the specimen was sent for a microbiology and histopathological analysis, which revealed a pseudocystic cavity surrounded by a fibrous capsule and an intense inflammatory cell infiltrate. The cavity contains sections of the nematode characterized by thick multilayered cuticle, as shown in the image. The follow-up and cure rates, at the end of 1 month, we had 55% of the patients with complete cure. At the end of 2 months, 85%. And at the end of 3 months, all patients had complete cure of the disease. And this was a case, a 2-year-old child who was the youngest among our patient series, who presented with a lesion in the anterior orbit along with severe itching and proptosis for more than 6 months duration. She was referred from elsewhere. A patient was already on ivermectin and steroids, and on clinical suspicion, we sent her for an imaging technique. MRI orbit revealed a worm mass within the superior rectus and LPS complex, and due to the persistence of the disease, we did an anterior orbital exploration, and the worm mass along with the cyst was excised with a maximum complete preservation of the superior rectus and the LPS complex. So to conclude, Kerala is an endemic area for ocular dirofilariasis. It is a diagnostic challenge due to its varied clinical presentation. Clinical suspicion with imaging is a pointer to diagnosis. Treatment outcome is excellent with medical management. Surgical excision for persistent cases, and those complete surgical removal offer negligible recurrence. So how to control? Strengthening awareness among clinicians, public health measures aimed at vector control, prevention of misdiagnosis, and a control of stray dog population. These are my references. Thank you.
A filarial worm that is reachable should be surely reached and removed. No.
No,
And medical treatment which you gave,
yes, sir.
where in which instances did you give medical treatment? Where were the microfilaria?
Majority of the patients, that is in 55% of the patients, they had an eyelid mass, while remaining 39%, they came with an orbital.
So those eyelid masses, you just gave medications and they became all right.
Yes, sir. Initially, we were given medical, the patients were given medical management, that is tab albendazole along with prednisolone, and almost 85% of them had complete cure, that is, they were devoid of the disease.
And the mass stayed, no? The mass regressed.
Yes, sir, mass regressed completely.
Oh, surprising. I believe that once a worm is lodged somewhere, no other choice but to remove it. But I'm not sure whether you'll give a medication, allow it to die and stay there forever. Then surely it will create a foreign body reaction.
For conjunctival visible worm masses, we directly did a surgical excision, while the other eyelid masses, we initially gave the medical management and we waited. If it was persisting or if there was a recurrence, then we did a surgical excision.
Okay. How many, in your series, how many cases now you have?
33 patients were studied,
33
sir.
patients. And those patients, anytime you saw recurrence?
No, sir. We only 5 patients we did a surgical excision, and we sequentially followed them after 1 month, 2 months, and 3 months. After 3 months, almost all the patients had complete cure. Until now, they didn't have any recurrence. The patient didn't come back to us with recurrence.
Any patient needed steroids then?
Yes, sir. The steroid was given along with anti-helmintic. All patients.
Anywhere you saw these filaria lodged elsewhere in other systems? ENT systems?
No, sir.
CNS?
No, sir.
Why Kerala is very common, you told, no, endemic something.
So there are various factors which is favoring the growth of the vector, that is a mosquito, that is humid climate, then abundant rainfall, then even stray dog population, as the dogs are considered to be the reservoir host. It is also a contributory factor to promote the disease.
What about the lungs involvement? Because he told about ENT and all. No?
Yes.
What about the lungs? You know, commonly the lungs are getting infected, or cardiac, heart and all may be infected.
Yes, sir. It also causes a pulmonary involvement, but in our study group, we didn't find any other
You have checked?
Sir?
You have taken all the
Yes, sir.
investigations?
Yes, sir. We didn't find any other systemic involvement of the parasite.
Oh. You have tried only ivermectin?
No, sir. According to our hospital policy, we didn't give ivermectin to a single patient. And as I showed, the baby, she was given ivermectin, and due to persistence, we started on surgical management. So we
Do
didn't.
you know some other filarial worm which can produce blindness, river blindness?
Cysticercosis.
Cysticercosis. No. Filarial, which can produce Onchocerca volvulus, transmitted by
Onchocerca volvulus.
transmitted by you don't know, it's a fly, Simurium black fly. You should know all these things because that onchocerciasis is included under 2020 program when WHO introduced. Okay, India we do not have agreed, but you should know something about the WHO programs which were included as a PG.
Okay, sir.
Last question, can you answer? What is Wolbachia? WOLBACHIA. Wolbachia.
Sorry, sir.
You tell correctly, I will tell Sankar Netralaya madam to donate you 10,000 rupees. No, she is very rich. Hello. You don't know. A Wolbachia is a rickets that is on the surface of Onchocerca. Normally resides. It's a actually a mutual understanding between them. Symbiotic life. Now, when you're treating filariasis,
Yes, sir.
that river blindness case, you are giving ivermectinol, whatever thing is there. In addition, you have to give antibiotics also, because to overcome this Wolbachia is a antibiotic to be given. You know the reason? Wolbachia helps in reproduction of your Onchocerca. If the Wolbachia is killed, actually they cannot reproduce. That's the way for control of that. In addition to ivermectin, they give antibiotics also. Just know this.
Okay, sir.
Okay.
Okay, sir.
Thank you very much.
Thank you, sir.
Curiosity, just like how in tuberculosis we can expect a delayed autoimmune reaction decades later. Can we expect such kind of autoimmune reaction in these patients too? I mean, your study was 8 years, none of them had a recurrence but can it be expected?
It causes usually a local inflammatory reaction.
Okay, so there's no systemic manifestation, just like how neurocystic cirrhosis can be anywhere.
Yes.
This worm is it only localized? It can also be anywhere, right? So should you have a periodic follow up such patients?
Yes, ma'am.
Should we consider giving them a medical card, telling them anything to do, any inflammation, fever,
Yes,
anything, they
we have
should carry this with
advised the
them?
patient that if there is any inflammation or any symptoms which is been persisting, or if it is recurring, then to follow up immediately.
Recurrence in what term? Was it against a worm or again as a asthma, it's an autoimmune reaction? Delayed autoimmune reaction.
Any inflammatory process in the body, if it is recurring, then the patient has to be followed up. Thank you.